Good morning. It's 8 o'clock, so we're going to get started. So it's my pleasure to introduce Dr. Sachedina. He's an interventional cardiologist who completed his medical training at the University of Toronto. That's where he got his MD and did his internal medicine. Then he moved to a place that I hold close to my heart, which is the University of Western Ontario in London, where he did his cardiology and interventional cardiology training. And last year he moved to Texas, where he's doing additional training in interventional heart failure at the Center for Advanced Cardiopulmonary Therapies and Transplantation in Texas Medical Center at the University of Texas in Houston, where he's been focusing on percutaneous mechanical support devices, management of cardiogenic shock, and also doing TAVRs. Now for his young age, he's had a number of awards and recognitions, including the John D. Brown Resident Memorial Award at Western University, Research Award of Excellence of the Division of Cardiology at Western, and actually he was the first recipient for the Charles Kerr Award from the Canadian Cardiovascular Society. And it's a pleasure to have him here today. He's applying for one of our jobs here in interventional cardiology. And he will be, he's got a pretty catchy title today, so let's see what's he got on for us. Is the Goldilocks Conundrum, Finding the Mechanical Support Device That's Just Right. So Dr. Sachedina, thank you very much for doing this, and take it away.
Thank you so much for having me. So you might be wondering why it's called the Goldilocks Conundrum. And part of the reason is that my wife and I had our first child last year, our daughter, and we have been reading way too many children's books. And one of her favorites is actually Goldilocks and the Three Bears. And because I've been reading this book so much, I actually did a little bit of research into the background of Goldilocks and the Three Bears. And I found out that it's actually based on an older story called The Three Bears from the 1830s that didn't have our beloved character Goldilocks in it, but actually a very old and angry, bitter lady who entered the house of three bachelor bears and basically wreaked havoc. And now, as you can imagine, this story has gone through many iterations on its way to becoming the Goldilocks and the Three Family Bears that we've learned to love. But one of the themes that has been maintained constant throughout the entire progression of this was the search of our protagonist for that thing that just fit just right. And that got me thinking about cardiac disease and our quest for mechanical circulatory support and management of cardiogenic shock. As we know, in recent years, we've had an advent of significant amounts of technology to help support us in the fight against cardiogenic shock. And yet we are still questing for the search in that for that device that can really treat our patients and really support all forms of cardiogenic shock. Now, as we know about percutaneous mechanical support devices, they give us time. They function as a bridge to allow treatment of the underlying cause of the patient's cardiogenic shock. They're basically giving us support so that we, as the cardiac team, can institute whatever therapy the patient needs to correct their underlying issue. Now, the percutaneous mechanical support devices come in many different forms. We probably have the most experience with the intra-aortic balloon pump, which is our pulsatile pump, but it does depend on a degree of preserved LV function to be able to augment cardiac output and help the patient. We also have the Impella CP pumps or other Impella 5.0s and 5.5 that can sit within the left ventricle itself and actually suck blood from the left ventricle and eject it into the aorta. And then we have the centrifugal pumps, which are the tandem heart pump, and which has both a drainage cannula that sits across the interatrial septum in the left atrium to drain blood that is returning from the lungs, and then is ejected in a retrograde fashion into the descending aorta. And finally, we have the percutaneous ECMO devices that drain blood from the right-sided system close to the right atrium, and then ejected in a similar way in a retrograde fashion into the descending aorta also. Now, unfortunately, despite the advent of these great technologies, the evidence really hasn't panned out in the way that we were expecting when we look at mechanical support devices in cardiogenic shock. The few randomized controlled trials that we've had, despite the fact that there has been few numbers of patients in them overall compared to some of our other cardiac trials, have not really shown any superior device compared to balloon pumps, for example, in all comers with cardiogenic shock, and balloon pumps themselves have not been shown to be superior to optimal medical therapy in cardiogenic shock. And we also know that these devices are quite costly and resource intensive. They often require dedicated personnel. And due to the long period of stays that most of these patients have when they require one of these devices, it also can be a significant cost to the hospital system also. So when I decided to come to Texas to gain more experience in the use of percutaneous MCS devices in the management of cardiogenic shock, I had two big questions I wanted to answer. And the first one was, can we do this? Is this possible for us from a percutaneous fashion to do safely, quickly, and efficiently? And the answer is overwhelmingly yes. We can deploy these devices very quickly in a safe fashion, and we're getting even better at it as we get more experience. But probably the more important question I wanted to answer was, should we do this? Are these devices really useful for patients in cardiogenic shock? And when and how is the appropriate time to go about using this technology? So as we know, in cardiogenic shock, the problem is basically that the heart and cardiovascular system cannot meet the demand that the body is requesting in terms of oxygen use and consumption. And this leads to a cascade of deleterious effects that begins with cardiac dysfunction and basically ends with critical organ dysfunction. When we look at the definition of cardiogenic shock, mostly from the trial literature, there tends to be some common themes. So patients in cardiogenic shock tend to be hypotensive or require inotrope or vasopressor medications to maintain their blood pressure. They have an element of pulmonary congestion, and that in the trial literature can be defined either clinically or with chest X-ray findings, for example. And all the patients have evidence of decreased end organ perfusion, and that can be anything from decreased urine output, lactic acidosis, or even altered mental status or other clinical findings. The hemodynamic definitions of cardiogenic shock come into play in some of the trials, but because they require invasive hemodynamic monitoring to see that our cardiac index is reduced or the wedge pressure is high, they're not included in all the trials, but are still an important part of the definition. So when we ask ourselves then, despite the advent of these technologies and all the gains that we've made over the past many years with primary PCI and STEMI, for example, has there been a major change in the mortality of patients with cardiogenic shock post-MI? And unfortunately, the mortality rate in this patient group is still very high. It's still 30 to 50% in all comers. In 2019, David Baran in the SKY group released a new classification for cardiogenic shock that divided patients with cardiogenic shock into 5 categories, starting with the at-risk group in stage A and progressing all the way to stage E, or the extremist group, who are in refractory cardiogenic shock and often requiring active resuscitation. And what they also found was that when they classified patients with cardiogenic shock according to this model, it did correlate with their overall mortality. And you can see that with the in-hospital mortality increases as we move up through the stages towards the extremist stage E group. So when we actually look at the role of percutaneous MCS devices in these patients, what the MCS devices are doing are trying to restore the balance between oxygen supply and demand, and try and get patients back from this cascade of deleterious effects in order to give us, the treating team, an opportunity to intervene and correct the underlying cause. Now, the different devices do exert different hemodynamic effects physiologically on the left ventricle. As we know with the pulsatile intra-aortic balloon pumps, for example, that they do cause a mild decrease in afterload and augment cardiac output minimally, while the rotodynamic pumps, for example, with the tandem heart and Impella, because they are reducing LV preload, they have very different effects on the left ventricle. And with veno-arterial ECMO, for example, while this can completely replace a patient's cardiac output if required, it actually does increase wall stress and afterload on the LV, which has some other considerations as well. The different pumps have different mechanisms, as we know. They're able to augment cardiac flow or replace cardiac output to varying degrees. The intra-aortic balloon pump is able to augment cardiac flow the least, while, as we mentioned, VA ECMO can completely replace your cardiac output. But as you move up towards more aggressive forms of percutaneous MCS support, you're also having increases in sheath size, which can correlate to increased complications from a vascular perspective, for example. The different MCS devices all have different contraindications as well. One major consideration is most of these devices are difficult or relatively contraindicated in patients who have severe peripheral vascular disease, just due to their relative size and the need for adequate vascular access in these patients. And particularly for the Impella tandem heart and VA ECMO, these patients tend to require anticoagulation while they're on the devices to prevent clots from forming within the pump itself. And therefore, patients who are having a bleeding diathesis or coagulopathies or an active uncontrollable bleed are also relatively contraindicated from receiving these devices also. So when we look at the use of percutaneous MCS in the current realm of cardiogenic shock, there are basically three domains that the PMCS devices are used the most. The first is in high-risk PCI. The second is in cardiogenic shock or established cardiogenic shock. And then the last is in cardiac arrest and resuscitation. And we're going to go through the use of PMCS devices in these three domains with some cases as well. So the first group I wanted to talk about is the high-risk PCI group. And I wanted to tell you about a 70-year-old patient who presented to our institution as an outpatient. So this gentleman had a history of coronary artery disease with previous PCI to his LAD. And he presented to our outpatient cardiology clinic with a several month history of intermittent chest discomfort. He also had a history of peripheral arterial disease and had a previous stroke with no residual deficits at this point, as well as some other cardiac risk factors also. On presentation, he did have a microcytic anemia, and he also had a history of GI bleeding in the past. As part of his workup, the patient had an echocardiogram, and you can see here that his LV systolic function is relatively preserved. But when we went and proceeded to do an angiogram, given his history, you can see that he actually has quite severe coronary artery disease with complete occlusion of his right coronary artery and severe disease affecting his left coronary system. He has ostial left circumflex and LAD disease. And on an alternate view here, you can see that he also has distal left main disease and mid-LAD stenosis also. So the patient was presented at a multidisciplinary rounds that included interventional cardiology, cardiologists, and cardiac surgeons. And after examination of the patient by the different services, he was deemed not to be a surgical candidate. Because of his microcytic anemia, the patient also had an urgent endoscopy completed that showed some AV malformations that the GI team cauterized, but no other significant lesions. And in anticipation of potential PCI, after the patient was deemed not to be a surgical candidate, he was placed on dual antiplatelet therapy for a period of 5 days at full dose and did not have any significant bleeding. So after all of these steps were taken, the decision was made to proceed with PCI for this patient. So the next question we wanted to ask ourselves was, with this patient's severe left main disease and triple vessel disease, did we need to use a mechanical support up front for this patient's high-risk PCI? So when we look at the literature to help us answer this question, one of the major trials that's been done was the PROTECT-2 trial to try and answer this question. And the PROTECT-3 trials, interim results have come out, but the final trial results have not been released yet. But when we looked at the PROTECT-2 trial, they basically randomized patients to either receive the Impella 2.5 in further high-risk PCI or just intra-aortic balloon pump support. Now, their inclusion criteria involved doing a non-emergent high-risk PCI on a patient who either had an unprotected left main or when you're working on the patient's last patent conduit with an EF less than 35%, or having triple vessel disease with an EF less than 30%. And what the group looked at was the combination of major adverse events, which included death, stroke, MI, and a number of other factors. And they looked at outcomes about 30 and 90 days. Now, with the intention to treat population, unfortunately, there was no major difference noted in the adverse clinical events for the population at 30 or 90 days. However, the per protocol analysis suggested potentially that there might be a difference at the 90-day mark for these patients. However, when you looked at our patient, he had preserved LV systolic function. And so again, after in that same multidisciplinary conference, it was felt that we could proceed with the PCI without a planned MCS backup in place, but that we would actually establish a 4 French sheath on our contralateral femoral artery in case we needed to deploy something quickly. We did decide on the DK crush bifurcation strategy up front for the patient's disease, and we used an EBU guide and a femoral approach, and we wired both vessels. And on our very first balloon inflation, the patient basically became quite hypotensive. That was refractory to emergent medical therapy and had a PEA arrest in the lab. Now, his downtime was very short because we did have an Impella in the room still within its packaging, ready to go. And because we had that contralateral femoral access in place, we were able to deploy the Impella device very quickly within minutes. At that point, the patient had complete resolution of his hypotension and arrest, and regained consciousness and was interacting with us without any obvious focal deficits. And we were able to continue the PCI as planned. And we did end up doing the DK crush bifurcation strategy after fixing the mid LAD as well. And this was our final result. The good thing for the patient as well was that he was able to be weaned off of his Impella during the case, and had it removed prior to leaving the cath lab. So the question becomes, well, in our patient who had preserved LV function and didn't quite meet the high-risk criteria that's been established by these trials, what were we missing? Why did this patient have the deterioration that he had with that first balloon inflation? So currently, to date, some of the major high-risk criteria has basically looked at mostly anatomical and anatomical parameters for the coronaries and LV systolic function specifically. But what we're starting to learn more from, particularly with newer literature that's coming out, is that high risk probably includes several other characteristics also. The patient's hemodynamics are becoming a really important consideration, whether they have preserved cardiac index or even elevated LV-EDP prior to the intervention. And also other characteristics from a demographic perspective, whether their age and frailty status, and whether or not they have any other contributing comorbidities. And one area that hasn't been looked at too closely, but is starting to become more prevalent, is operator experience as well. Obviously, someone who's encountered a higher number of these rare cases might be able to better troubleshoot some of the problems that come up invariably in this very high-risk patient population. And so when we look at percutaneous MCS use in high-risk PCI, we know that MCS can be a valuable tool in high-risk PCI, but unfortunately in all comers, to date, no trial has shown randomized evidence benefit from a mortality perspective. And part of the reason for this is likely in how we define these high-risk patients. And it may be, and what we're learning more so, is that it may be as we specify better the definition for high-risk patients and appropriately label these high-risk individuals, that we might actually be able to start seeing the signal of benefit that we expect in this patient group. I also wanted to talk about the use of percutaneous mechanical support in established cardiogenic shock also. And I wanted to tell you about another case that we encountered this year. So this is a 68-year-old male who had been experiencing chest discomfort for 1 week prior to presenting to hospital, and who was found to be in decompensated cardiogenic shock with heart failure as well. He did have a previous history of CABG that was done in a different city, and unfortunately we did not have any records of his operation and did not know where his grafts were. And he did have several other active medical comorbidities also. Now, the patient had been experiencing chest discomfort for 1 week with worsening symptoms of heart failure prior to presenting to hospital. And when he did, he was found to be hypotensive, tachycardic. He had evidence of renal dysfunction with no prior history of severe renal abnormalities, as well as lactic acidosis. Now, the patient was started on inotropic agents at this peripheral hospital, and an urgent echo was completed there. And what they saw was that on an initial look, it looked like his LV was operating pretty well. But as we know, particularly for patients in cardiogenic shock, when you see this type of characteristic with an almost hyperdynamic wall, it sometimes means that the patient's actually experienced a mechanical complication. And you can see here that the patient has an aneurysmal and akinetic apex. And when we actually colored the patient's septum as well, and in fact, he has a ventricular septal rupture with left to right shunting across the VSD. And the shunt was actually pretty large in nature as well. So the next question we want to ask ourselves, well, for patients with a mechanical VSD or septal rupture after an MI, what's their mortality rate if it's unrepaired and the patient goes into cardiogenic shock, just like our patient? And if you look at the literature, in fact, the mortality rate is 100% for these patients if they don't receive some sort of intervention to correct that septal defect and manage their shock. Now, the literature would also suggest that the survival rate for these patients can actually improve if you're able to delay their surgery a little bit. Now, I think this has a little bit of intrinsic bias built into itself, because obviously the patients who are stable enough that you can delay their surgery a little bit are likely to do better than the patients who are very sick and need to be taken urgently for some sort of corrective intervention. However, when we also speak to our surgical colleagues, what I've learned is that particularly after a mechanical complication or VSD rupture in this case, that the tissue is often very friable in the initial period, and that actually makes it harder and more dangerous when trying to do a corrective repair. We took the patient for a left heart catheterization as soon as he arrived at our center, and you can see that he does have complete occlusion of his LAD just after that first septal perforator. And when we did an angiogram of the patient's grafts, interestingly, you can see that his Lima graft does not go to the LAD as we might have expected. And in fact, he has a saphenous vein graft that is going to a diagonal branch and then appears to be a skip graft from there to the LAD. And you can see that that limb is going to the LAD is actually occluded as well and is likely the acute cause of the patient's infarct. So at this point, we stopped, and as a multidisciplinary group, we asked ourselves, what should our next step be? This patient is very sick and is not doing well, and there was a discussion of whether or not we should send the patient for urgent surgery on his current level of support. We also had a discussion on whether we should place a mechanical support device as a potential bridge to surgery, and importantly, we also did discuss palliation with the patient's family as well. His wife and daughter were very involved, and what we learned about this patient is even just a few weeks prior to his presentation, he was playing tennis. He'd recently retired and was very active and had an excellent quality of life. And after an important discussion with the patient's family, they said that if he was able to talk to us right now, he would ask for any sort of high-risk intervention, even knowing that the outcomes might not be very good, in the hopes to try and give him back any sort of that level of quality of life that he was used to. So the question that we then asked ourselves is, can we get this patient to surgery? And is there a mechanical device that can help us get there? So we did consider using an intra-aortic balloon pump at first, but we didn't think that it would be able to augment the patient's cardiac output enough to improve things as he was deteriorating quite rapidly. We did consider using an Impella pump for this patient, but we were concerned about two things. Number one, because the pump was sitting in the left ventricle, we were worried that it could damage some of the friable tissue even further around the VSD, or if it was sitting too close to the defect itself, whether the suction mechanism on the Impella might actually pull deoxygenated blood from the right ventricle and cause a right to left shunt. We did think about putting the patient on full support with VA ECMO. However, as we know, VA ECMO does increase afterload and filling pressures in the left ventricle, and we were worried that this would actually cause further shunting across the VSD. So that left us with the tandem heart. So for anybody in the audience who's not had much experience with the tandem heart, what it is two different cannulas. And similar to ECMO, the outflow cannula or arterial cannula does sit from a femoral artery approach in the descending aorta, but the drainage cannula, instead of sitting in the right atrium, actually crosses the interatrial septum after the implanting team performs a septal puncture, and it sits in the left atrium and drains blood that's returning from the lungs to the left side of the heart. So we're actually draining oxygenated blood and basically bypassing the left ventricle. And it can provide pretty excellent levels of flow. It can provide almost similar to ECMO in terms of 2 to 5 liters per minute of flow if needed. And it's very effective at unloading the left ventricle. The nice thing about the tandem heart is it can also be converted to a VA ECMO circuit by pulling the drainage limb back from the left atrium into the RA and attaching an oxygenator to the pump so that the blood can be oxygenated as it moves from the right side of the heart to the left. So we felt that this would be a good option for this patient given his VSD, and using intracardiac echocardiography, we were able to perform a septal puncture from the right atrium into the left atrium, and this is what the drainage cannula looks like when it's sitting in the left atrium. So on the tandem heart circuit, the patient was weaned off all of his inotropes and pressors within 24 hours. He had complete normalization of his renal and liver function within 3 days. And he was extubated and was able to speak and interact with us. And he eventually went for his operative repair. We maintained him on the tandem heart device for just over 2 weeks. And he went for a repair of the VSD and bypass of his RCA, as we also noted on the angiogram that his RCA graft was occluded. And the best part about this for this patient is he was actually discharged to rehab 7 days after his operation. He had a very rapid recovery post-op. So when we look at the tandem heart device, then the other question was, well, could this be a mechanical support option for all patients in cardiogenic shock? We know that the tandem heart device can improve cardiac index, can help with mean arterial blood pressure, and also can improve renal perfusion and urine output. And we know that from a metabolic perspective, it does decrease lactate and improve renal function, as mentioned. And when we look at the studies that have completed on tandem heart in all comers in patients with cardiogenic shock who received a tandem heart device, overall the survival in this population was 60% at 30 days. However, a meta-analysis was completed in 2017 that included the tandem heart devices that have been done in randomized trials in comparison to the intra-aortic balloon pump. Now, I will point out that the number of patients included in these trials is relatively low, but overall, despite that, what the meta-analysis suggested is that there was no mortality benefit for the tandem heart compared to the intra-aortic balloon pump in cardiogenic shock. And so why is this happening? Why do these studies keep showing this? Are the studies too small and not including enough patients? Are the patients who are receiving these devices not sick enough? Is it that the devices themselves are coming with their own set of MCS complications, which are diluting the benefit that they're providing to our patients? Or is it just overall that these devices are not really as beneficial as we think they might be? Now, all of these things might be correct, but one other important factor that is likely contributing to the outcomes of these trials is that cardiogenic shock is a very heterogeneous disease. And when we talk about all comers in cardiogenic shock and the definitions that are often used in a trial, patients with septic shock, for example, can often have similar parameters with respect to hypotension and evidence of decreased end organ perfusion, similar to a cardiac patient. And obviously those diseases are very different. Even for patients with established cardiogenic shock, often the underlying cause is completely different. As you can see for the patient on the left, this patient was having an inferior STEMI that was due to a mitral clip that had embolized and basically blocked off the RCA, while the patient on the right is a pregnant lady who had massive bilateral pulmonary embolisms during her pregnancy and required intrapulmonary catheter-directed TPA as well as thrombectomy to help correct her underlying cardiogenic shock. Now, both of these patients would have met the definition for cardiogenic shock as stated in these trials. However, as you can see, they're completely different and requiring completely different therapies. And that's true probably for most different forms of cardiogenic shock. Cardiogenic shock itself is probably not a diagnosis, but more a final common pathway of these very varied disease states. And just as these varied disease states require different interventions, likely our percutaneous mechanical support devices have to be tailored to these different problems as well. So in summary, for the use of MCS devices in established cardiogenic shock, we know that the MCS devices can be a valuable tool when used in the right situation. And to date, as we know, no trial has shown randomized benefit with a mortality benefit, but it's likely because we are trying to look for a mechanical support device that fits all comers. And so if we kind of shift our focus towards looking at MCS devices as different options of treatment or different options of support and tailor it to a patient's physiologic and hemodynamic needs, it might be that we have better success, particularly from a literature perspective, showing benefit of these devices in the right situation. The last group of patients that I wanted to talk about was the use of mechanical support devices in the extremist standpoint, or those patients who are actively arresting. And I wanted to tell you about another case. So this is a 60-year-old male with a history of heart transplant for prior non-ischemic cardiomyopathy. And his first year of after receiving his transplant, his course was actually fairly uncomplicated. He did have some mild cellular rejection that was treated, and on his 1-year angiogram, he was known to have the beginnings of cardiac allograft vasculopathy. So this angiogram was completed about 4 months before I encountered him. And as you can see, the patient is starting to develop some coronary disease, particularly in the LAD. And you can see that his distal left main is also showing some signs of stenosis as well. And it's a little bit more visible from this view also. Now, this patient, again, this was his 1-year post-transplant left and right heart catheterization, and his hemodynamics showed preserved cardiac index, and his echocardiogram did not show any signs of dysfunction. And after this angiogram was completed, the patient was actually referred to have an outpatient stress test done, as he was asymptomatic. And given those findings, the plan was to potentially intervene if there was any signs of perfusion deficit. Now, unfortunately, this patient missed his appointment and missed the follow-up appointment that had been made for him due to personal reasons. And a few months later, about 5 days before his admission, he had an episode of chest and arm pain for about 1 hour that resolved on its own. At this point, he didn't call his transplant coordinator. He didn't call his cardiologist. He thought that he had just strained his arm while doing some physical activity. But a few days after that, 2 days prior to his admission, he started to develop some worsening dyspnea, orthopnea, and noticed a little bit of peripheral edema. And he finally presented to the ER in the early hours of the morning where he was actually found to have this ECG. Now, as you can see on this ECG, this is very concerning. The patient has evidence of ST elevation both anteriorly and inferiorly in lead 3, as well as ST elevation in AVR. And the patient does have significant signs of ischemia elsewhere also. And if there are any learners in the audience today, this would be a very concerning ECG for a patient who potentially has left main involvement for an acute coronary syndrome also. Now, the patient in the emergency department did receive a dose of IV Lasix. He diuresed very briskly and well, and he was seen by the cardiology CCU resident on call. He was also seen by the cardiology fellow on call, and the case was reviewed overnight with the cardiology attending on call. And as it was in the early hours of the morning, and the patient stated that he was feeling quite a bit better after receiving the Lasix and diuresing, the decision was made overnight that the patient could wait to be the first case in the morning in the cath lab, which was only a couple hours away. So the patient was admitted and started on medical management for presumed acute coronary syndrome and rejection. And I think this is an important learning point for trainees as well, that it's important to remember that in these transplant patients, because they're denervated, they don't necessarily feel chest discomfort or other symptoms in the same way that patients with their own native hearts might. And so even in those few short hours, while the patient thought that he was feeling well and the medical team thought that he was feeling well, there was likely more things going on in the background. And in fact, when the cath lab team went to pick up the patient from his room to be the first case, he actually had a PEA arrest right in front of them and immediately had CPR started. There was a very short downtime because he was talking in front of them, and then the next second he was gone. And he received 15 cycles of CPR up front. So that's already a half hour of CPR. So we now have to ask ourselves, well, for an inpatient who experiences an in-hospital cardiac arrest and receives continuous or prolonged CPR for greater than 20 minutes, well, what is their survival rate? And unfortunately, for these patients with prolonged resuscitation, their survival rate remains less than 1% in the inpatient population in all comers. So while this patient was receiving CPR, a heart team discussion was held at the bedside, which included heart failure and transplant team. It included cardiac surgery, it included interventional cardiology and some general cardiologists as well. And it was felt particularly from the heart failure and transplant team that, this patient had been doing pretty well prior to this deterioration. And if we were able to salvage the patient, that he would potentially have an exit strategy, even requiring a repeat transplant if needed. And so with that in mind, we did cannulate VA ECMO at his bedside in his wardroom, and that was done fairly quickly. And once the patient was placed on VA ECMO and had stabilized, we took him directly to the cath lab. Now, if you remember his previous imaging, you can see that there's quite a difference now. The patient has a complete occlusion of his right coronary artery. And unfortunately, his left coronary artery also shows significant deterioration. You can see the distal left main is very stenosed, and he actually has complete occlusion of his LAD as well. What may be even most concerning from this imaging is you can see that the backflow of contrast into the aorta is basically just falling right back through the aortic valve into the left ventricle, suggesting that his left ventricle isn't even contracting enough to push any of that contrast out into the aorta. So with the patient on full VA ECMO support, we were able to wire the LAD, and we also protected that other large branch that you can see there also. And we went on to do PCI of both the mid-LAD and that bifurcation. And interestingly, on the very first balloon of the LAD, where we felt the occlusion, acute occlusion was, the patient regained pulsatility and some contractility from his LV. We went on to do, again, a bifurcation stenting strategy as we were on full support with VA ECMO. And this is our final result here, as you can see. We were able to reestablish flow to the LAD as well. So as you can imagine, the patient did take a significant hit to his left ventricle. This was his echocardiogram completed immediately after the procedure. And his LV, as you can see, is not moving very much. He also had a Swan-Ganz catheter placed that showed that his wedge pressure was very high. His left-sided filling pressures were very high. And due to the risk of pulmonary edema and the increased afterload that we know is that it can occur with VA ECMO, the patient had an intra-aortic balloon pump inserted from the femoral approach to basically help offload the LV as well. Now, on ECMO and intra-aortic balloon pump support, the patient's inotropes and vasopressor requirements began to decrease. The ECMO was eventually decannulated 5 days after his cardiac arrest, and his intra-aortic balloon pump was discontinued 8 days after the arrest also. Unfortunately, the patient did have a prolonged ICU stay for some other reasons. He had a GI bleed during the admission, He also had an ECMO site bleed where the cannulas had been placed. And due to his immunocompromised state, he ended up developing HSV viremia as well. However, the patient was discharged from the ICU 5 weeks after his arrest, and an echocardiogram completed at that time did show a significant improvement in his LV function, as you can see. The patient also had a repeat angiogram, and you can see that his coronaries have perked up quite a bit. His stenting of his LAD is intact, and when you look at his circumflex system as well, and the LAD system, they are providing some collaterals to the RCA, which we saw was occluded. So when we look at eCPR or ECMO-assisted CPR, what it is the addition of a VA ECMO circuit to a patient who's actively being resuscitated with CPR. It's often done from a femoral approach urgently, and we know that in fact that it can increase survival to discharge to 30% in this patient population. And as we had mentioned earlier, previously this patient population had a survival rate of less than 1% at 6 weeks. Now, the advantage of ECMO over some of the other percutaneous MCS devices is that there's relatively few contraindications to ECMO. As we mentioned, because of the peripheral vascular access, that having severe peripheral vascular disease can make cannulation quite challenging. And one of the other advantages over, with ECMO over the other devices is that it does not depend on adequate LV function like an intra-aortic balloon pump does, or adequate RV function such as the tandem heart or Impella, which need an RV to be contracting well enough that it can move blood from the right side of the heart to the left where it can encounter the tandem heart or Impella cannulas. And so ECMO can completely replace a patient's cardiac and lung function if required. However, it does have some disadvantages as well. Because of the anticoagulation requirements, patients often have issues with bleeding or vascular complications, and a patient who's having active bleeding or coagulopathy is at quite high risk when they are placed on VA ECMO. The device, as I mentioned earlier, unfortunately also increases wall stress and increases afterload on the heart, which can worsen LV filling pressures. And particularly if a patient does have increased filling pressures from ECMO, this can lead to worsening pulmonary edema and eventually pulmonary hemorrhage. And there is emerging evidence that potentially for all patients on VA ECMO, that a venting strategy for the LV up front might lead to better outcomes. But what eCPR or ECMO-assisted CPR is really doing for us is giving us time. Just like the other mechanical support devices, we are buying time to allow the medical team to intervene. And because of that, selection of the patient becomes paramount. It's important when we're selecting a patient to have someone who has a potentially reversible condition. And if the condition itself is irreversible, the patient should be a candidate or amenable to definitive therapies, whether that includes an LVAD or transplant, for example. And our hope is that for patients who we are selecting for eCPR, that they do have minimal comorbidities, and so that they do not have other competing interests that could potentially worsen their quality of life or shorten their lifespan. Now, we have identified several poor prognostic factors that lower the rates of survival in patients who are receiving eCPR, and some of these are, as you can expect, related to worsening acidosis and evidence of tissue hypoxia in the form of high lactates. But what we've been found to correlate the best in terms of survival is a minimal low flow time. So when we ask, well, what is low flow time? Well, if we were to divide the delivery of eCPR into 5 stages, including the pre-arrest stage before the patient actually arrests and the different stages until they're actually placed on ECMO, the low flow stage would be numbers 2 and 3 here, as you can see. So the low flow stage would be from the initiation of the cardiac arrest to the time of CPR initiation, and from CPR initiation to actually ECMO cannulation when the patient is now receiving full support. And what we know is that if we can put systems in place to limit this stage, and that includes having a team that can quickly assess these patients and determine their candidacy, that the shorter the low flow time, the better survival overall that these patients have. And because of the improvements that have been made to ECMO cannulation, as well as to the devices themselves, and the fact that this device can now be done percutaneously in a fairly straightforward and rapid manner, the use of ECMO, particularly in the United States, as you can see here, has gone up astronomically in the last several years. And in fact, there are several areas now that are actually looking or have created a mobile ECMO units. And for example, at the center that I'm currently at, our mobile ECMO team can travel to a peripheral hospital, and due to the small size of the ECMO circuit, which is only a little bit bigger than a briefcase now, the patient can be cannulated on ECMO at a peripheral site and then brought back to the tertiary or quaternary care center where they can continue to receive optimal care. And I believe that there are certain areas in Canada that are potentially looking towards trialing this sort of technology as well in a mobile fashion. So we've talked about a lot of different areas of cardiogenic shock today and the use of percutaneous mechanical support device. But I think when we talk about looking for that mechanical support device that fits just right, what we're starting to learn is that there is no mechanical support device that fits just right. And the reason for that is that, as we discussed, cardiogenic shock is too heterogeneous. Our patient populations who are coming in cardiogenic shock often have very different diseases requiring very different levels of support and different treatments overall to help correct their underlying cause. But because of that, the shift now is moving from not which device fits just right, but which patient actually fits the device. And as you move towards selecting our MCS devices based on what a patient requires physiologically and hemodynamically, I expect that the literature will actually hopefully show more benefit to these devices in a randomized setting. Now, with one of the wonderful things that Canada has is the current landscape of Canada is very conscious of the fact that the mechanical support devices are a limited and valuable resource. And because of that, Canada is very well poised to ensure that when we're looking at the research, that we are identifying these patients better and in a way that we can hopefully prove that it's the patient itself that determines the device, not the other way around. And what we do know is that it requires teams to be able to do this. And in particular, it requires a multidisciplinary heart team comprised of specialists from all the different levels of cardiac disease, including our allied health nursing teams as well, in order to treat these patients to the full extent we can and hopefully improve their outcomes. So I just want to say thank you so much for the opportunity. I hope that you found this lecture interesting as well. And I'm happy to answer any questions.
Well, thank you very much, Ayaaz. That was great. We do have a couple of questions here already on the our chat box. I don't know if you can check your chat box also.
Well, let me
The
see.
first one comes from Dr. Clark, who's our leader for the Advanced Heart Failure Group. And he has questions that giving varying physiology and cardiogenic shock, PA catheter-guided decision-making makes sense when considering patients' potential value for percutaneous mechanical support. For acute MI shock, do you make these decisions in the cath lab or post-PCI in the CCU? And if in the cath lab, what additional parameters do you use to place percutaneous mechanical support at the time of PCI?
So it kind of depends at our center on what the status of the patient is. If they're actively deteriorating in front of us, we tend to make that decision right in the cath lab itself. And we use their hemodynamic parameters. So we're pretty quick to even just do a right heart catheterization in the cath lab at the time of their PCI, and at least just get a swan in a few seconds to give us a little bit of hemodynamic data on where exactly the problem is. And with that, for example, if someone is showing signs of significant RV failure in addition to LV failure, it might change the device that we're considering using in that patient up front. Now, what I've also learned is that even just putting a balloon pump in up front, particularly for patients with acute MI who are showing signs of cardiogenic shock, actually overall does give you a little bit more time to be able to make those decisions. But once we have some hemodynamic data, that's when we decide in the cath lab what device that we're going to use.
Great. So here's another question here from Dr. Schnell. He's our CICU director. So he asks, if you only have one choice for percutaneous MCS, which would you choose, tandem heart or Impella?
So
go ahead.
I think that I would say ideally the tandem heart has a lot more flexibility. However, I am very much aware of the fact that the tandem heart takes quite a bit longer to put in. And the reason for that is that, number one, if we use intracardiac echocardiography here to be able to visualize the intraatrial septum. But even if we're going to use TEE, it still takes time to do the transeptal puncture, get the cannula across the left atrium, and then implant the arterial limb in the aorta. And particularly if someone is deteriorating before your eyes, at least from me, I would think that the rapidity of deployment is probably part of the consideration, and the ease of implanting an impella is a little bit nicer than having to do a transeptal puncture emergently on a patient as well. So for our center, we tend to use the tandem heart a little bit more when we have a bit more control over the situation and have a little bit more time. Otherwise, so in this standpoint, I would say that if I had to pick one, I would probably pick the impella up front, just because of the rapidity of deployment.
The other question was, back at your institution there in Texas, do you use a PA catheter in all cardiogenic shock, or how do you decide that?
So for most patients who are in cardiogenic shock here, they are our center, because of the way it's built, is only one of two shock centers in Houston, and that's a catchment area of 4 million people. And so we tend to get funneled the kind of the worst of the worst, and so because of that, we tend to use PA catheters here quite a bit, particularly in the initial stage, to help guide us exactly where the problem is. Is this left ventricular involvement or biventricular involvement? And then we don't often keep the PA catheter in during their whole hospital course, but we do use it up front to try and determine some hemodynamic data.
Okay, could you expand a little bit on what's the complement structure for a shock team, and what do you have there in Texas?
So the team that we have here is kind of the hub and spoke model, as I mentioned. So our shock team is comprised of dedicated interventional cardiologists, heart failure and transplant cardiologists. We do have a couple members of pulmonary critical care who sit on the shock team as well as several cardiac surgeons. And because of that, there is a one member from each of those groups on call for the shock team every night, and during the daytime as well. And if there is a call for a potential shock case, particularly from one of the peripheral hospitals, there is a quick conference done on the phone that includes a representative from each of those groups. And let's say if someone else is doing a case, one of the other members of the shock team will just step in if the person on call is not available. And there's a quick discussion on whether this patient is eligible for for transfer to our center, and whether they would benefit from any device up front as well. And so because of that, and because they've been doing this here for quite some time, it's a very efficient and rapid system, and they're able to kind of get everybody's input within just a couple of minutes. And so that's kind of the setup from the hub and spoke model here. We also have a dedicated person on call that will travel to the site if necessary to deploy the person on specifically for ECMO only. So if the patient can be transferred to our center without requiring ECMO, they would be transferred by life flight or critical, and we would see them upon arrival. However, if it's felt that the patient would not be safe for transfer and does need a mechanical support device deployed, our representative who's on call that night would travel with the team and go deploy at the peripheral center and bring them back. So there's obviously a significant cost to these resources. However, particularly as we know, we are doing a lot of the transferring of patients from peripheral centers to tertiary centers in Canada as well. And so the additional personnel is not very much, because the person on call basically travels with that team.
Yeah, on that note, Dr. Har wanted to, he's one of our interventional cardiologists, is asking that, given the limited and valuable resources, is there any data on costs to run a full ECPR, ECLS team, including the personal equipment and hospitalization afterwards?
I think that there have been cost studies that have been done in the US specifically, but to be honest, I think that the cost here is not necessarily representative of what might be achievable in other countries or institutions. And part of the reason for that is that the cost in the US system is basically put on the patient directly, whether it's through the patient's own personal funds or through their insurance companies. And because of that, I think that sometimes there's a little bit of a markup, I would say, on what is being offered. But as far as I know, from a Canadian perspective, the cost has not been looked at yet.
Okay, Dr. Howlett is another of our heart failure guys, is asking that, given the fraught degree of the literature, what would you say would be the most important factor in showing benefit for this resource-intensive option?
I think that the most important factor for the world in terms of moving forward is going to be patient selection. As we know, we've trialed with different devices. Now, even as early as the balloon pump, I think we can all say that we've seen a situation where a balloon pump really helped our patient before our eyes. And yet all of the evidence that we have would suggest that the balloon pump is no better than optimal medical therapy. And I think what it comes down to is what we kind of discussed about earlier, is that our current definitions of cardiogenic shock or high-risk patients are very all-encompassing, and include patients who are very different from one another. And because of that, I think that's where we're running into trouble with the literature. And from just to kind of tie that with the resource and cost perspective, I think that it's going to be up to us in the medical profession to show that there's a benefit to this prior to anybody considering the investment that's going to be required in order to start using these devices the right way. And for me, that's going to come down to patient selection. And what we're learning more is that if we do select the patient appropriately and then use that as the springboard to choose the device, at least from our own personal experience, we are achieving better outcomes rather than kind of lumping them all into a cardiogenic shock group and trying one device.
Okay, well, that's great. Any other questions? Doesn't look like. Anyways, well, I think that was great. Thank you very much. So what do you think in the future would be, do we need to have all these different technologies available, or can we just, focus on one or two and have a shock group? What do you think is the future going to look like?
I think personally that the future is going to look, particularly in Canada, the future is going to look like, as you mentioned, having a shock team. I think that we're learning more and more that having that immediate access to our professional colleagues and their input is invaluable, number one, and allows us, as we mentioned, to kind of triage these patients rapidly and efficiently. And as we know, the quicker that we can implement the right therapies for the patients, the better they do. So from that perspective, a shock team model can be really useful. From an MCS device perspective, I don't think we need all of these different devices. And I think the cost of managing all of them is too high. However, if we do invest in one left-sided device support, in addition to ECMO, I think that would be really beneficial, because the wonderful thing about ECMO is that it can really completely replace the amount of support that you need, as it can act as, as it can function to be both your lungs and your heart. And so from that perspective, it is the obvious choice in a situation when you really need the highest levels of support. However, because of the issues that also come with it and the dedicated personnel, having a specifically left-sided geared device support as well in addition to that would only be helpful and hopefully reduce costs also.
Okay, well, thank you very much. That was a great informative talk, and we'll be getting in touch a little bit later.
Perfect. Thank you so much.
Enjoy the weather in Texas.
Thank you. Take care.
Okay, bye now.